now to Estephanie Dunn, who's going to be chairing this event, who's the Regional Director for RCN's Northwest region.
Thank you. Thank you very much, Sarah, for that introduction, and welcome to everyone who's joined this fourth event in the series of Nursing a Pandemic. I am really delighted to have you all here, but particularly delighted to have our two guests who have agreed to be interviewed to support us in understanding the leadership role around nursing the pandemic and caring for people involved in it. We'll start, as Sarah has said, by interviewing each in turn. Trish Armstrong-Child, who is the Chief Executive of Southport and Ormskirk NHS Trust, and Trish Bennett, who is the Chief Nurse at Mersey NHS Trust. And thank you both very much for agreeing to speak with us tonight. And you can say a little bit more when we start your interviews, just to give people an insight into your professional backgrounds. So thank you very much. So I think we've agreed to go in turn with each Trish. So to avoid confusion, and you didn't have to be named Trish to be on this panel tonight. So Trish Armstrong-Child has agreed to respond to the questions first. So before we start, Trish, can you just tell the audience a little bit about yourself, just a couple of minutes?
Yeah, of course. So hello everybody. So yes, we did alphabetical order, so I'm going first with the Armstrong-Child. So so I'm Trish. I am the Chief Executive of Southport and Ormskirk. I've been here for around about 16 months. It's my first Chief Exec post. Prior to that, I'm a nurse by background and trade. 33 years in the NHS as a nurse. So previous to this post, I was the Director of Nursing and Deputy Chief Exec at Bolton Foundation Trust. So 33 years as a nurse, just come up the ranks really. I started actually as a healthcare assistant, went on to do my training in the traditional sense in the schools of nursing, and have held lots of positions in terms of staff nurse, went on to be a sister, a matron. I've done some operational work. I've been a deputy director of operations. So I've done quite a variety of roles, but as I say, my last role was the director of nursing, but I'm very proud to say that I've kept my registration up and continue to practice, because as my husband describes me, if you cut me down, there was a stick of rock, it would say nurse through me. I'm extremely proud to be a nurse. Thank you very much.
Thank you. And Trish, can you tell us a little bit about yourself?
Certainly, Stephanie. Delighted to be here this evening, and thank you very much indeed for inviting me. My name's Trish Bennett. I'm the Director of Nursing and Operations for Mersey Trust, which is a community and mental health trust. I'm coming up to 39 years as a nurse, and have, like Trish, done a variety of roles, from staff nurse right through to being executive nurse in commissioning, as well as provision. When nurse consultants were very first introduced, I was one of the first in the country at that time. We've done lots of different roles and different providers, both commissioning and provision. And I have a joint role now as the Director of Nursing and Director of Operations.
Yeah, thank you, Trish. You both have some very challenging day jobs, and you probably didn't need the pandemic to sort of be overlaid. And I think one of the things for me, and my first question is about how, you know, Trish Armstrong, who's going first, how did you become aware of the pandemic and the potential impact that it would have on the NHS and the services that you provide?
Yeah, so looking back now, sort of a year on, if I think about probably December, the December before, obviously like everybody else, I was watching with interest what was happening in Wuhan state and the television that was emerging out of there. And in my previous role, I was also a Director of Infection Prevention and Control. So I'd lived through some of these things before around Ebola, SARS. So we'd all, you know, that kind of preempting of, you know, how big is this going to become? And at that time, it seemed a little bit unclear. And if I reflect on it now, for those coming months, sort of the December, January and February, it was a bit like watching something in slow motion. So there was always the possibility, but it was, is it really going to become a sort of an international incident? So started watching on the television, and then slowly within the UK, obviously there was more and more alerts coming through to us in terms of the national alerts. So from our organisational perspective, we were sort of setting things up almost in ghost form. So we'd started the silver operation, then, you know, by the end of January, it felt very much like, right, we need an incident room, we need to get into full incident mode. But everything at that point still felt on standby. And one of the things I reflect now, I look back to the February board papers, and I always do a chief executive update. And in the February board paper, which would have been the beginning of February, I was reporting 13 confirmed cases in the UK. I mean, 13. And within sort of 6 weeks of that, we'd gone into this sort of full-blown major incident, and the rest is history, so they say. So confirming that at the February board, and I always remember, and it's always one of those things in your career, where were you? Taking a call regionally in March, and by that point we'd set up daily sort of incident room meetings, and we were having a what if kind of scenario with all our clinicians. And I was called out of that meeting to take a regional call, and what the call said was things were starting to progress in London, and it was very clear that this was something now that was definitely in the UK, and it was coming up the country, and obviously we were in the northwest. And I took a call from the region that said, okay, what we've now got to get into is we need confirmation from you that you can increase your critical care 5-fold within the next few days. And I can remember sitting in this office taking that call thinking, wow, 5. So I'm going to increase my capacity of critical care by 5 times. And I remember leaving this office and going just down the corridor to our teams, operational teams, and some of our clinical teams, and talking to them about what was required of us. And it was all from the learning from London that was coming out. And I just remember the sort of silence in that room of, really, we need to do that. And the room was palpable. And then within a couple of minutes, everybody started kicking into action. So it felt very sort of like a slow build. I can remember a colleague of mine from London ringing me on that Friday, and it really hit London to say, this is brutal, this is real. So it felt like a very slow motion, and then it was just here, and then it just happened. So that's what it feels like on reflection now.
Thanks for that. And that's within your first few months of taking up this role as a chief executive, and straight into it at the deep end. So gearing up your critical care capacity times 5 is quite significant. So can you tell us a bit about how your working days evolved, you know, during the weeks, the days, weeks and months during this pandemic, particularly in the early stage where you were scaling up?
Yeah, so I think it almost felt like, you know, once the button's pressed, you just go into it. And for those that are joining us today, you know, a large proportion of us will have at some point been involved, unfortunately, in some sort of major incident in our career, but they tend to last, you know, hours or days. This was different because it was a bigger scale, and clearly we knew it wasn't going to be an event that was going to be over. So when I think about it, it scaled up very quickly and it stayed there. So the working weeks and months ahead of that, from probably March onwards, really, were pretty full on. So it was 7 days a week. So there was no sense that, right, well, now it's Friday. It was very intense because the picture was changing so quickly. So being able to not even preempt, but to react very quickly to what was being asked of you was really important. So setting up the goal structure was really important, and sort of as the chief executive taking the leadership role in that, but having the right people around the table with me to make those decisions, because this wasn't a time where we could deliberate. We had to make decisions there and then and kind of take them. So that structure of gold and that cascade down was really important, but the 7 days a week was extremely challenging. And we always talk about the importance of rest, but certainly for that initial first wave, it was a matter of, it was constant and it was intense. And you know, many of us are used to an on-call rota, but this was different to an on-call rota.
Yeah. You talk about silver and gold, and there might be people on the call who don't understand what those structures mean. Can you very briefly sort of describe that, and clearly your leadership role in that?
Of course, yes. So we very quickly nationally went into a command and control structure, which is what we describe sort of in the emergency planning as level 4 command and control. So that means quite clearly people need to take direction. So the gold and silver is that we would have a gold command, which is the senior executives that would be taking the sort of strategic overview, making sure that we implement the instructions that are coming down. That would be then supported by the silver structure, which is the operational teams, which are basically the guys that have to go then and implement it. And making sure that structure is tight, and making sure that the operational teams are working with us to be able to tell us what's working, what's not working, what support they need is really, really important. So that's what we put in very quickly. But one of the other things that we put in was something called a clinical reference group. So I always talk about, probably because of my background, the best organisations, regardless of pandemic, are those that are clinically led and operationally managed. And what I mean by that is the clinicians know what to do. So when we were getting instructions about what we need to do, so for example, increase your intensive care 5-fold, my sense was, it's up to the clinicians to be descriptive on how that's going to work, not for us to tell them, you know, how it should be. So the clinical reference group was meeting on a daily basis. So that was some of our most senior clinicians, but it wasn't just doctors, it was nurses, it was allied health professionals, to come up with, this is the scenario that we need to face today. Tell us the best way that we can support this clinically. And that's how our structure works. So we had the gold and silver and the clinical reference group, because anything we implemented, we needed to make sure we did it as safely as possible.
Thank you very much. And you had many challenges, and I was really going to ask you what your biggest challenges were and what kept you awake at night. And I'm drawn to increasing your critical care capacity by times 5 must have been a huge challenge. Were there others?
Oh gosh, well, we probably wouldn't have too long in here to say what kept me up all night. There was lots of things, because there's always the things that you don't anticipate. But I suppose the thing that kept me up all night was that overwhelming sense of responsibility I felt for the staff and their welfare. And I'm a great believer, and always have been, that if the staff are okay, the patients will be okay. So what kept me up all night was the ask that we were asking of our staff, and it was an impossible ask. It felt like an impossible ask, but there was no other option. And some of the subtle things that kept me up all night, or some of the decisions we made at the beginning that kept me up, and still do actually, are just things that I can still remember the day that we made the decision to give 24 hours notice to the public that we were stopping visiting. That really kept me up. So it had to be done. It was the right thing to do from a safety, but knowing the impact that was going to have on the patients here, the loved ones and the family not being able to come in, and our staff actually, that was, and still now, we're obviously still in a very restricted visiting area now. You know, it is something that we constantly review, but those kind of decisions were really difficult decisions, because you understood the human impact that was going to have.
Yeah, thank you, Trish. And in the middle of all of that, what support was available to you to sustain your own health, well-being and resilience, given that you were working 7 days a week, long days, I imagine?
Yeah, well, I guess, you know, as you get into leadership roles and you sort of climb through the ranks, so to speak, you know, you do kind of learn the importance that when you're in a leadership role, the importance of your own health and well-being, and it's not a selfish thing, it's a necessity, because for you to be all right, for everyone else to be all right, you've got to be all right. So there's a saying, isn't there, who motivates the motivator? So I think in a leadership role, like any role actually, there's a couple of things. So where do you get your support from? Mainly your peers, for the people around you working on a day-to-day. And I think in a leadership role, one of the key things is it's okay to be vulnerable. It's okay not to be okay. And it's okay for sometimes others to know that, really. So taking on that role in some ways, particularly in a leadership role, it helps staff see that you're human too. So all that kind of training I'd had through sort of, leadership development about the importance of looking after myself, and sort of, almost grown up in an NHS of a family and camaraderie, I knew where to get my support from. And I'm just very blessed as well in terms of family and getting that support from the family as well. So number one is always make sure that you're all right to be all right with other people.
Yeah, thank you very much indeed. One of the things that we saw was quite stark. Many nurses, particularly those from ethnic minority backgrounds, succumbing to the virus. What action did you take to support your nursing staff and to manage their own concerns, particularly as loss of life was a key feature?
Yeah, so I think for me in this organisation, it was about recognising it very early on, recognising that there was absolutely, something that was transpiring, to say that there were staff who were certainly looking like they were at higher risk, and what I did, or what I was really conscious about, was at the time there was lots of sort of proposals about what should happen, how we should be looking to support our staff, particularly from our BME backgrounds. What I was very keen to do was, before we put any action in, I went to talk to the staff themselves, because I think that's really important. Rather than tell staff what you think it is, go and listen to what they think it is. And you can't have a kind of one size fits all approach either. I think that's really important that we. So I spent quite a lot of days and weeks actually when it started to emerge in terms of the pattern and the picture of speaking to staff either on a one-to-one or small groups, and asking them what they thought and what they thought the solutions were. And I'm so glad I did that, because, as I say, not one size doesn't fit all. We brought risk assessments in, formal risk assessments in, very quickly within the organisation, and looked at the sort of the priority of that. And we listened to staff. We increased the health and wellbeing. And one of the things we did, I think, particularly well here is where we could, possible, a lot of our staff moved to working from home. So my corporate management office, there was staff there that started working from home, but very quickly got into identifying who those staff were. And unfortunately, we did lose a nurse during the pandemic. A nurse lost her life, and I will never forget that phone call on a Saturday evening from the team to tell me. Never ever forget that phone call. And that ricocheted through the whole organisation, and still does. So I guess the approach is always going to be recognise it, be aware of it, but just know one size doesn't fit all. Listen to people and listen. Everybody's worries are different.
Thank you very much. And like you say, it's probably a call that you will never forget, and as will many of your team. Yeah, it's been a very sad time. One of the things I don't think we can ignore is the issue of PPE, particularly during the early phase of the pandemic, when we heard many reports and concerns about adequacy of supply. How did you prepare for and respond to these critical safety issues? And what did you do to reassure staff, service users, families and communities that the measures were in place?
Yeah, so again, I suppose one of those things about what kept me up all night in the early days, that was one of the things that was clearly on my mind, because obviously the reports coming in up and down the country of issues around availability of PPE. I guess certainly from this organisation's perspective, we were really lucky in terms of we never got to a point in this organisation where we ran out of PPE and had to think of an alternative. And I will always feel very, very grateful for that. So in terms of how we manage that, we, again, going back to the sort of gold, silver command, we very quickly got a structure in place where we had on a daily basis an overview of all our stock in terms of where it was, down to individual, you know, gloves and where everything was. And we worked out in terms of how much we were using on a daily basis, how much supply we had. So we always knew in advance. So, you know, thank goodness from an organisation perspective, we never got lower than 3 days supply of stock. So we always knew at what point we'd potentially run out, and putting that sort of 7-day service in to make sure that we got it. And then what we did was make sure that staff knew that. That was a very clear message that, you know, there is PPE, don't get into any myths of thinking there isn't any. And then we put in things like a ward liaison officer who could go out, because again, what I knew in a gold command situation, I wanted to make sure that was going right the way down to the workforce. So if I was assured that there was PPE out there, it was important that staff did. And in the Northwest, and Trish may touch on this, but again, we were very lucky that we had a really good mutual aid system. So if I was holding on to 7 days worth of stock and my neighbouring trust was down to 1, I wasn't going to hold on to another 7 days. And it was very much, so there was a really good intelligence network to make sure that there wasn't anybody that was going to go without. And we started to do that with, once we got in a more comfortable position, we were able to do that with local nursing homes. It was amazing in the first days, whereby we were just getting calls from local colleges saying, we've got some PPE here, should we bring it in? So there was a real sense of camaraderie, goodwill, and certainly across Cheshire, Merseyside, that we did not want any inequity across any of the trusts. So we were very fortunate. But again, getting that message out to our staff and getting the comms out, and staff knowing that we did have supply, was really important for us.
Yeah, thank you. And I'm mindful of time, just maybe a last question. What's your experience of the vaccine hesitancy in your trust, and what action have you taken to support your teams to consider and actually take the vaccine?
Yeah, so we have we're one of the vaccine hubs at the Southport site, and we went live from the first week in January, offering vaccines out, and we offered them out to our staff. Again, quite lucky here, because we have quite a good record in terms of our flu vaccination uptake. We normally get about 92% uptake every year, so we've got a good track record for vaccine. So we've actually vaccinated about 14,000 people across our hubs now. But of that, when we break it down, we're probably around about an 87% of substantive staff that have been vaccinated here. And again, because we know there are staff in high risk groups, we're very keen to make sure that we offer that out. So at the minute, for us, we have of the 87% overall vaccination, we've got 94% of what we class as our clinically vulnerable, so our staff that we're shielding, that have done the uptake in that, and we're around 85% for our BAME staff. Now, we actually know it's higher than that, because that's recorded for staff that have come into our hub, but we also know the staff that had it outside our hub. So we're just doing a piece of work now around that. So two big things we probably did to promote that was, we took a decision quite a few months ago that we would do a weekly team brief live with the executive team, and our medical director would talk about the vaccines, where it was up to. People had an opportunity, if they were unsure or worried, and they could ask a question. And we've continued that, actually, and there's less questions about the vaccine, but it's there. And every chance my medical director gets, he talks about the importance. And then the other thing that we did was, I took the opportunity about quite a few months ago now, that when we started to get the figures in, I personally wrote out to all what we would class as high risk, so all our staff that were known as clinically vulnerable, and all our staff from a BAME background, I personally wrote out to them to say, we really want to make sure that you are supported. If there's reasons why you still, not determined on whether to have it, please come and talk to us. Here's my direct contact. Please contact me directly or speak to our health and wellbeing. So that went down very well, actually. So that was several hundred staff to personally write to. It was definitely worth it. And I got quite a lot of one-to-one feedback from staff for the reasons why they didn't want to have it. And it just helps us to understand. And going back to my point before, you can't put an action plan in before you listen to people. And that's really important. So it's an ongoing process for us, really. So and something we look at on a weekly basis now.
Thank you very much. And that's, quite a successful approach to vaccinating your staff, and particularly those who are vulnerable. Thank you very much, Trish.
Thank you.
Trish, I'd like to welcome you to respond to the same set of questions. Thank you very much for agreeing to talk to us. And can you tell the audience a little bit about yourself in a couple of minutes?
Yes, thank you, Stephanie. So I, in my role as the Executive Director of Nursing Operations, I also have a lead board responsibility around emergency planning, and so naturally took on the gold command of the incident. I think recognise, Trish's, how this happened almost in slow motion at first. Some slight differences in that obviously what was coming through nationally was pictures out of Italy in terms of ITU, very much focused on acute services, and that's understandable. But for a mental health and secure mental health and acute mental health, learning disability and community trust, we had to think very hard about what that would look like, and started to prepare in terms of an incident management three weeks before the incident was actually called. And so my crystal ball's no better than anybody else's, Stephanie, but you could see, it was obviously the numbers were coming up every day. People could see what was happening on the news. And really the preparation for me as the goal commander in that role was to prepare the organisation and to make sure that the battle rhythm in terms of running the incident, the tactical silver role was in place. We had time to put that in, time to prepare. And so we took an earlier stand on the goal command. Some of that was actually related to previous roles I'd had in commissioning, where, preparing for pandemics, and use that experience in this case. I can't say I knew that what was going to happen, of course. I don't think any of us did, but started to prepare the organisation from a goal command point of view, making sure all our business continuity plans were reviewed at that very early stage in terms of being ready, and making sure that the battle rhythm, the response, the reporting to the board arrangements, etc. was in place. I was supported also with the development and the setup of a clinical cell, which our medical director took a lead on, and also an ethical cell, which was extremely important and very valuable. And we are continuing with an ethical cell in the organisation. And, we had certain challenges throughout the incident, particularly for our most vulnerable people with mental health, learning disability, dementia, etc. So that was the role I took at the beginning and continue to take now. Making sure that the incident was run 24/7, and also that staff knew where the leadership was. They knew that it was with me and the team, of course. I was very, very well supported by my colleagues, and we got into the running of an incident quite quickly in this organisation.
And your organisation is very different to Trish Armstrong-Child's.
So we had different challenges. It's a very diverse organisation, from pre-birth, health visiting, right through to end of life in terms of community services. So lots of our district nurses, our teams working out in communities with particular challenges. and our mental health service from a very acute right through to high secure, which are clearly difficult situations with outbreaks, etc. And older people, mental health services and dementia, and very diverse in terms of the geography. So spanning a range of about 40 miles, with services in different boroughs, different places, different ICSs, and making sure that the message is, of course, getting through to all of the teams, and the visibility that's required in these situations.
Yeah, so achieving that visibility, working across those different systems and geographical boundaries must have been quite challenging. So can you tell us a little bit about your working day, weeks and months during this pandemic, and what kept you awake at night?
Yeah, so like many others, it was generally a 7-day week role at that point, like many other people, like many of our frontline staff, and it needed to be. Clearly, you know, breaks are taken, you catch some time, you know, perhaps at the weekend, etc. But in the early part of the incident, you had to be able to respond not to what was happening in your own organisation, and certainly we had to do that, and that information coming through the tactical gold command route, but also to respond to what was happening in the system and the very unplanned calls, system calls, national or regional calls that needed some response as the incident started to, and the pandemic started to unveil itself. In terms of the organisation, one, you know, the challenge of allowing and supporting people to do their job, which you know, in simple terms, absolutely had to happen. How do you really help our staff do the job in this situation? To how do we help others? How do we help other organisations? And as Trish said, certainly in the Northwest and in this area in Cheshire and Merseyside, very strong camaraderie between the organisations, absolutely a real effort around mutual aid. And so I was very conscious that not only was I asking my own staff to do the job in their own organisation, I was asking them to go beyond that and to support other areas. For instance, in our nursing and residential home. So our district nurses, matrons, our infection control nurses, swabbing teams, setting up swabbing teams very quickly. So there was two tasks really. There was the running of the organisation through the incident, and there was the response that was required in the wider system. And those two things had to be managed, organised, and supported.
Yeah, very challenging indeed. And the same question I'll put to you: what support were you able to have to sustain your own health, well-being, and resilience whilst working in that way?
A number of things, Stephanie. One, you know, our amazing staff, watching, supporting them and what they did and how they rose to the challenge gives you a real purpose and support, and gives you that extra energy when you see how they are, as challenging as it was. I have a very supportive board who would take time to ring, to offer support in any way they can. Our non-execs who had been, you know, had a particular experience around pandemic at work. I found that really helpful. The organisations across the patch themselves, there was a real camaraderie between the directors of nursing and the leadership from NHS England and the CCGs, and generally, obviously my own family. As Trish said, you're very blessed with the support, and taking some comfort in small things, you know, taking some time to maybe watch something, or to take a few minutes to read something that would just take, you know, give you some headspace really. Just going back to the point, Stephanie, about what kept you awake at night. Well, certainly at the beginning, the availability of PPE kept me awake. We were also fortunate here in that we were well stocked with PPE. We were also in a position where, from a goal command, we were clear about usage, what that looked like over 1, 2, 3 and 7 days. We were never in a point where we didn't have stock available. And the key was getting that message out to staff in all the communities, in all our mental health areas. That was certainly difficult at the very beginning. I think also what was very challenging was, so infection control guidance at that point didn't actually cover mental health or community services. It was very much based on acute. These things are all understandable in the situation, but we had to interpret and work with that and make sure that the guidance was applied appropriately and meant something to our staff and for our patients. And I think also in terms of being able to swab patients and staff in mental health, that took some time to work its way through to mental health and community staff. So that was also quite challenging, particularly as outbreaks started to happen and we are looking at isolation. So that was quite difficult. All of those things were addressed on the way, but at the very beginning, it wasn't there for mental health, LD and community staff. From a swabbing point of view, that became normal and available as we move through the incident. So they were the things that kept me awake.
Yeah, plenty there. And again, one of the things we saw was the impact of the disease or the virus on people from an ethnic minority background, and many of them succumbing not just to the virus but losing their life. What action did you take to support your nursing teams and manage any concerns they had when faced with that on a daily basis in the news, and in reality what was happening with their peers and families?
So very similar to Trish, the risk assessment process and the accurate risk assessment quickly, swiftly in place at the earliest opportunity. The opportunity to allow people to work at home, to support them, those that were shielding, and to do that consistently across the organisation. Keeping the dialogue going, so the frequently asked questions, the communication out from gold, the one-to-one meetings with people, very, very, very important in these incidents. And we've kept that going all the way through the incidents until this day. From a patient point of view, in terms of shielding, patients who were shielding, we took a role in terms of our patients on our mental health caseload to call them every week. 8,000 people, just a call, are they okay? A touch base. And the same with our staff, and doing that, sort of keeping that communication going with them. Working from home or shielding, of course, can be a very lonely position also, and being very aware of the impact of this on people's mental health. So having a wraparound process around psychological support. Certainly where we had outbreaks, we provided that very quickly for our staff on our mental health wards. So psychological support, absolute visibility of our infection control team. So they're with them, helping, supporting the teams. Things like bringing uniforms in within 2 weeks. So, that's not a normal thing in mental health and learning disability organisations, secure service to wear uniforms. It certainly is in community, but being able to do that very quickly, taking away some of the anxiety around their own clothes, infection, etc. There were some of the actions that we took, making sure that communications, frequently asked questions, availability, video consultations and virtual team meetings with the executives, the chairman, myself, chief exec, with the teams right through the incident has been equally as important. And working with our BAME network, listening, as Trish said, listening to listen to hear what are the issues and how can we make this better and support. So really taking that approach, Stephanie, it's a whole mixture of things there, but we've kept that going all the way through and continue to do that.
Yeah, thank you. We hear a lot about the psychological and mental health impacts of this whole virus, and in particular people who are isolating. 8,000 calls, quite a lot to do a week, but very important.
It is. And I think, in terms of mental health, Stephanie, for our staff who are wonderful, having to isolate, these are difficult things. That is not their normal day. So quite challenging, needing support, the importance of visibility around infection control, nurse leadership, absolutely critical in helping our teams through this.
Yeah, thank you for that, Trish. You've touched on PPE already, and I think the special circumstances of delivering services to mental health, service users who have mental health problems or people who have a learning disability cannot be underestimated, I'm sure. What was the impact of your staff wearing PPE, going from ordinary clothes into uniforms? Did that cause some challenges for service delivery in the...
Yeah, so in terms of uniforms, I expected it to cause more challenges than it did in terms of mental health and learning disability. In fact, the opposite has happened, and we are looking into a new trust uniform, and generally they're looking to have a uniform long term. So we haven't insisted on this at all. We've talked to the teams about whether they would want that, and they do. So the uniform was easier in lots of ways. It was very much welcomed. Masks were it was much more difficult in terms of PPE. So obviously the obvious challenges of nurses and healthcare practitioners wearing masks and PPE all day, long shifts. I think, that's a general issue, harder in some areas than others. There was a particular challenge, of course, for mental health and LD, and that is around the communication and how that was hindered. And that took, some really getting used to, making sure people kept the mask on, and the temptation to talk, express, certainly for our patients with mental health and LD, was a big challenge for us. Less so than the uniform, actually, but the actual wearing of PPE, particularly with our most vulnerable patients, was very, very challenging for our staff. Very challenging.
Yeah, can't be underestimated, that challenge. Thank you for that. And just again, looking at the issue of vaccine hesitancy and thinking about the people who work in your trust or use services you provide, what action have you taken to support teams and potentially long-stay service users to consider the vaccine?
So in terms of the vaccine, very similar to Trish in that we have a good uptake, an excellent uptake around the flu vaccine. So I think, we're at 80, the last time I looked at this last week, we were 86% in terms of the vaccination. I think 79%, over 79% on our BAME staff. The issues that we have where people are concerned about having the vaccine or haven't yet had the vaccine is really actually the national issues. So issues around impact on fertility, impact on long-term impact of having a vaccination, how will it affect them if they have certain conditions themselves. And the way that we have addressed that is to really bring some experts in when we can, so around maternity and fertility, leading by example, talking to staff individually, going out to talk to them, having the vaccine as easy in terms of geography as possible. And for our patients, also our long stay patients, we've run 2 programs, one around vaccinating our patients and one around vaccinating our staff. Again, vaccination for mental health patients came in much later. We got on and did it. We got on, which, you know, obviously that's the right thing to do, particularly if you think about patients with people with learning disability, the impact respiratory issues can have on them. And so some very innovative things have happened. Our staff with our PCN colleagues supporting the vaccination of our population with LD and doing that together. And just recently, over 400 in one community in Liverpool. So really brilliant stuff has happened in partnership. And, you know, we've had to think differently, Stephanie. We've really had to think differently with some of our patients and service users and how we do that.
Yeah, thank you very much indeed. You know, really challenging times, and it's really helpful to hear and heartwarming to hear how both staff at Southport and Ormskirk and your own trust, Mersey Care, have adapted and worked hard to support the people they provide services to. So thank you both very much.